And what about the diagnostic? You have CT, you have
So we have
magnets?
we have CT, we have a 0.4 Tesla magnet, and we have X-ray and ultrasound. So the order should be X-ray, ultrasound, CT, and MRI, which are the advanced imaging modalities. Here, as we are an oncological institution, we work a lot with CT. We often skip X-rays and ultrasound because patients are coming already with these more basic procedures performed. So most of our
So CT is like a father of diagnostics.
Yes, I would say yes. It's the main modality, especially for the oncology. It's where we can see the majority of problems. We can quickly see the full body of our patient, and where we got the, let's say, 90% of our diagnosis. Then in some cases we add, especially for the nervous system, for the brain, for spinal cord, we add the MRI. But we almost always start with the CT, because the MRI is a perfect tool for the brain, for example, and for the spinal cord, and for neurological medicine in general. But it is as a sole modality, it has some limitations because it can it's very focused on one region. So the risk, if you go only with this modality, is to miss some parts. So almost every patient for the oncology is having a CT usually. Even if he has a brain tumor, MRI is better in delineating maybe the tumor. It's an add-on to differentiate which kind of tumor, if it is really a tumor or if it is some other kind of pathology. But first of all, we need to do a CT. We need to do what we call staging, which means if a patient has a cancer, we need to check the lungs of the patient, the rest of the body, the lymph nodes, to be sure there are no metastases at the moment we start the treatment. Because
so that's very important. You don't do just one part of the body. If you do the scan of the entire body, so you can see.
Yes, more and more with the machines like this. This is a 128 slice CT, which means it has a capacity to scan with a single rotation a very big area. So in few seconds we can scan the entire body, which means that many patients can receive the scan even without anesthesia, just with the sedation or with a very short anesthesia. And we are able to see the whole body and make conclusions based on the whole body, because in the past the limitation was we were maybe scanning, because the technology was not so advanced, only one part, and then adding maybe some X-rays, which are less sensible. Nowadays we have a very detailed image with CT. We can go lower than 1 millimeter, so we can find micro metastases, micro nodules.
Yeah. He catches all, everything.
Yes. So sometimes too much. Sometimes too much. So we have to be good doctors, in the sense we need to decide what is the crucial point and what is the real pathology, and exclude what is not important. Sometimes in a full body CT, in a old dog, we can find many things that needs to be assessed, and not everything needs to be always treated.
Okay. Yeah, and we were talking about anesthesia a couple of minutes ago, and a lot of vets don't recommend CT to older dogs because of dangerous.
In general, anesthesia itself is not is not dangerous. It's always a condition where the body can react differently from the normal awake body. During anesthesia, all mechanisms that are compensating the normal conditions can fail. So that's why anesthesiologists need to be there, monitor, see that everything is okay, because things can be unstable during anesthesia. But if there is an anesthesiologist and if anesthesia is performed correctly, most of the times it's not dangerous procedure. There are patients where it can be dangerous because they have some bad pathologies and they are unable to compensate. So we have to select our patients, but the majority of patients are able to have an anesthesia performed correctly. Very few cannot have an anesthesia. We have cases where we prefer not to anesthetize the patients and do just a very mild anesthesia or sedation, and with this machine we can still have very diagnostic images even in a sedated patient.